Hello, I'm Nancy Brown, Dean of the Yale School of Medicine. Welcome to this webinar. In this seminar, we will hear about the potential of scientific discovery to lead to improvement in lives. Today, we will hear from members of Women's Health Research at Yale. This important interdisciplinary research center focuses on developing and supporting laboratory and clinical studies that advance our knowledge on the health of women and uncover the influence of sex and gender on health outcomes. Since its founding in 1998, the center has been recognized as a national model for launching new research and has garnered funding to study some of the most important causes of illness and mortality for women. In addition, Women's Health Research at Yale has funded over 100 pilot studies. These have supported early and mid-career faculty who require these resources to launch their research on topics as diverse as cardiovascular disease, cancer, autoimmune diseases, Alzheimer's disease, autism, depression, and COVID-19. These studies provide the initial data necessary to secure larger external grants that grow into programmatic lines of research needed to overcome an historical gap in research on the health of women, and to generate new findings to improve the health of everyone. Besides the commitment to research, the center trains the next generation of researchers and clinicians and communicates its finding to the public and to professional communities. And now, as you will hear, Women's Health Research at Yale is partnering with the school's new health policy laboratory, Elevate, which focuses on community-based interventions for women and families and uses research to inform and to advance health policy, ensuring that historical disparities in health with regard to gender, age, race, and socioeconomic status are remedied. Thank you for taking the time to join us and enjoy the webinar.
Thank you, Dean Brown, and welcome, everybody. I'm Jocelyn Maminta, your moderator for The Way Forward. Now, this is a discussion on how science drives discovery and how studying the biology and social experience of women advances knowledge and guides us into a healthful future. Before we begin, a housekeeping note. There is a question and answer session at the end of this webinar. We encourage you to ask the questions through the Q&A function provided by Zoom, and we will try to get to all the questions, and we do want to hear from you. Joining us are two extremely accomplished women in their field. Dr. Megan Smith is the founder of Elevate and Associate Professor of Psychiatry and Child Studies Center at Yale School of Medicine. Dr. Carolyn Mazure created Women's Health Research at Yale and is the Spungen Bildner Professor in Women's Health Research and Professor of Psychiatry and Psychology at Yale School of Medicine. Welcome, Dr. Mazure, Dr. Smith.
Thank you, Jocelyn.
It's great to have you both with us. Well, let's begin with you, Dr. Mazure. What led to establishing Women's Health Research at Yale?
As Dean Brown alluded to the history of it, it was from the 1950s through the 1990s that biomedical research just grew by leaps and bounds in this country. And during that time, the National Institutes of Health were particularly influential in terms of being a center for research, but also being a tremendous resource for academic medical centers all over the country to build their research portfolios. But within all of that research, largely women were not studied. There are exceptions to the rule where there were disorders of very high prevalence for women like depression, in which women were included as subjects. But even then, we didn't take the time and the effort to really look at whether or not we should be examining outcomes on the basis of sex or gender. So in 1998, when things were heating up about the importance of looking at women, and the NIH was changing its requirements, it seemed like the perfect time for Yale to take the lead in terms of really designing a center that could fund and support efforts to really advance the health of women. One last thing I would say is that once we got underway, It was also very clear that we had a great opportunity to study sex and gender difference, and that would not only help women, but it would help everyone. And so we're very enthusiastic about that larger goal that we have.
You do focus on sex, gender differences. How would you define sex and how would you define gender?
Well, sex is used largely to characterize a biological classification. Generally as male or female, it's linked to reproductive organs and to chromosome complement XX versus XY. And in contrast to that, when people talk about gender, they're really talking about people's self-representation that comes from their sociocultural experience. And so it's an attempt by science to say, these are two very important areas that we have to study. And ultimately, to determine health, we have to look at both of those areas and integrate those areas.
Dr. Smith, what role does Elevate play when it comes to women's health?
Sure. Elevate is the policy lab I direct here in the School of Medicine, and Elevate is focused on advancing the science and the discovery that Dr. Mazure referred to that are being created and supported by women's health research at Yale. And so we're advancing that science and those discoveries in really a community context and policy context. So in many ways, Elevate's really translating or moving the science from laboratories, from an academic setting, into community settings that can benefit and improve the health of women. One of the ways that Elevate really is focused on doing this is by studying the link between women's health, and particularly women's mental health, things like depression and anxiety, and women's economic and social mobility. So we know that women's health and women's economic well-being are really, inextricably linked. And we want to understand more about how to intervene at a community level and then translate what we learn in science into policies that support women. And one key way that Elevate is doing this is really infusing the voices of women into the design and the conduct of research. So really understanding from women, and particularly low-income women, what are your goals around health? Where do you want to be? What do you want to achieve? And then trying to design interventions in science that supports those goals.
And you're having these conversations across the country. Elevate is, I believe, in a number of locations.
That's correct. We're excited right now to be in 5 states where we're replicating interventions around women's mental health and doing so with government leaders and large social service and health systems. We have more states coming online in the future as well. So we're really see this as a tremendous opportunity to benefit women's mental health overall.
Very good. And I want to remind the both of you to interject whenever you'd like. This is a conversation.
Well, Jocelyn, thank you for saying that, because I wanted to also point out, listening to Megan speak about her work, which is extraordinary, that it actually started here in New Haven. The prototype that she has now deployed to other cities and states was really developed here and is still being used here in New Haven to benefit women and families.
It's really important to hear all the different voices.
Yes, it really is. And I think another thing you might ask Megan about is the concept of going into the community to speak to women about what their needs are. In other words, we don't go and talk to women and tell them what they need. We go and talk to women and say, what is it that you need? What is going on in the community and in your life that could make a difference?
Well, Dr. Smith, how difficult is that, though, to go in and ask these questions? And do these women respond?
Yeah, so it's, actually when Dr. Mazure is talking about it starting in New Haven, actually the way that I became involved with women's health research at Yale was it really launched my interest and my knowledge and developed my research skills in this kind of research. So I was actually obtained additional training that was part of a training grant that women's health research at Yale received through the National Institute of Health that really allowed me to go into communities and talk to women and really conduct very rigorous research in that way. So, I can give you an example of that where we've done that. That's really, for me, made me a strong believer in this approach, which is we were looking at, what were some of the strongest predictors of postpartum depressive symptoms in a group of low-income women. And we were talking to women, women were advising us on some of our research and our questions, and women talked about diaper need. And they were talking about really the difficulty that many low-income women had in providing a sufficient supply of diapers to change their child as often as they would like. So we started looking at this question of diaper need, and we found that actually it was the largest predictor of postpartum depressive symptoms for low-income women. So as a result of that work, we published on it, and there were a number of policy changes that came out of that through different municipalities and state governments, really supporting this idea that diapers were actually linked to women's mental health. Now, we never would have thought of asking those questions had we not partnered with women to design these research studies. But it is difficult. It does require training and novel methods. And it also requires really intentional collaboration that's thoughtful and that really ultimately reduces health equities between academia and community settings that we're often acutely aware of.
That's interesting, because I am seeing an increased number of diaper drives now.
Exactly. Exactly. It's to our partner, the National Diaper Bank Network has been a phenomenal partner in that, and a research partner as well.
Dr. Mazure, what studies at Women's Health Research at Yale have really led to change?
So we have an embarrassment of riches there in terms of answering your question.
That's a good thing.
It's a good dilemma to have. Which studies might I pick? So as Megan's talking about community-based studies, I might point out maybe one clinical study that really had been enormously successful for us, and also maybe perhaps one what's called the basic science or laboratory study, just to give people an idea of the breadth of this. And I might also add too that it's very important, I think, to us to say that any disorder or condition that affects women falls under the rubric of the health of women. That when we started in 1998, if you said women's health, people really thought you meant reproductive health solely. We study reproductive health. We think it's essential to the lives of women, but it's just not all of women's health. Women's health involves cardiac disease and autoimmune disease and a whole variety of other conditions. And it also involves wellness. So we're interested in all of those things, and our portfolio really covers the waterfront in many, many areas. In terms of a study to mention that's a basic science study or a laboratory study, I turned to one that was particularly impressive to me, and I'm going to have to use a few technical terms, but I'll explain what those are. And so the study was really about an investigator, Dr. Peter Glaser, who's also a fantastic investigator and clinician in therapeutic radiology, had uncovered a benign cell-penetrating antibody. Okay, what does that mean? That means, well, probably a lot of us have heard the term antibody around COVID-19 and developing antibodies. So antibodies are proteins that the body develops in response to an invader. And as importantly, it also is responsible for remembering that invader so that if it comes again, the body can combat it. So Dr. Glaser determined that this particular antibody, which came from the disease lupus, actually, was benign but could invade cells. And he thought, well, this might be a great way to deal with various cancers that women suffer, as essentially carrying cargo of chemotherapy into a cell that was cancerous. Instead, what he found, and this is so true of science, you go in with one idea, but something else really turns out to be the case. What he found was, in fact, it did work, that these proteins did, these antibodies did penetrate these cells, both healthy and malignant cells. But what it did was, for malignant cells, it weakened them so that they were more responsive to various kinds of cancer-based therapies, which was an enormous step forward in terms of yet another way to approach cancers and cancer therapies. And this now has been moving forward into attempts to go to clinical trial and further developments, and has brought more grants in for him to study this in lines of research that all feed that various area. Because although we're making great strides in cancer, we still really are not yet close to our goal. And another way to attack cancer would be really a phenomenal success. So we're very excited about this. We think it's very important. The other study I would mention to you is different. And it's a study that is focused actually on kids. And when we started out, we had a certain amount of money. We had a certain goal. We were starting with women. We wanted to study adolescents. We wanted to study children. But we had to start somewhere. And there was such a gap in knowledge about the health of women that we focused on adults. But over time, our plan was to begin to study adolescents, which we have now done, and study kids as well. So this study with children is with children who are on the autism spectrum. And the study is about a particular kind of social behavioral therapy called pivotal response therapy, or PRT. And the therapy is a social therapy, a social experience. So a trained clinician works with kids, children who are on the spectrum, in an attempt to systematically reinforce appropriate behaviors during various kinds of play and interaction. And what we learned actually was that this type of therapy was designed with boys, it was tested on boys and used with boys and was successful with boys, but had never been tested for girls. And this particular investigator, Dr. Pam Vantola, came in with the idea that what she wanted to do was see whether or not this worked for girls. Well, for the particular category of individuals being studied at that point on the spectrum, the girls actually had more significant deficits than the boys. But when she compared boys and girls then using this particular therapy, she found that the net gain for girls was even greater than it was for boys. So it not only was successful, but it was more helpful to girls than it was to boys, even though it was very helpful for boys. And now it's being used as a therapy for girls as well as boys.
Well, I know that autism predominantly affects boys, so I understand why the study was predominantly, first was offered for boys. And it is interesting, the results. Dr. Smith, how do you take those results and bring it to the community?
So it's a great example of where translational science can come into play, of really moving the science from the academic setting out into community. So I think a lot of it is to think about where PRT, pivotal response therapy, can be disseminated in the way that can increase access to families who might have access to it. So, that could mean delivering in schools, for example, school-based health centers. It could mean placing the intervention in other community settings like after-school programs, and that would be another great example. And then also working at a policy level to ensure that there's reimbursement for effective interventions, for evidence-based interventions like Dr. Vantola's work.
And that is important.
And Jocelyn, just kind of in addition to what Megan was pointing out and what you raised, and that is that autism is more prevalent in boys than girls. Well, that's true, but what we're learning, however, is that if you build a taxonomy or a template around boys, then you really are only sorting for symptoms that are most evident in boys. And as we start to expand our thinking and move from very dichotomous or everybody fitting in a pigeonhole kind of thinking to dimensional thinking, thus the autism spectrum disorder term, that we start to realize there are more girls who have those characteristics than we thought. And I think as we do that kind of thinking, which is part of the evolution of science, part of what really prompts new discoveries, we are learning more and we're doing more to help people's lives. We're finding that this is the case too with heart attack. We have an investigator who's also a terrific cardiologist, Dr. Erica Spatz, who I think I introduced you to at one point. And what she's doing is trying to create a new taxonomy for heart attack, because approximately 20% of women between the ages of 40 and 55 who have heart attack do not have classic, so-called classic symptoms of heart attack. they have other kinds of symptoms. And in fact, as a consequence of that, even though they're having a legitimate heart attack, they're not picked up in the system. So if you build your taxonomies, you build your diagnostic systems just around males, you may very well miss symptoms and miss presentations that appear in women and girls as well.
I remember doing that study, Dr. Spatz. You actually mentioned, Dr. Mazure, COVID. So let's talk about that because obviously we're dealing with it right now. Are there any COVID studies targeting women?
Well, yes, there's actually two studies that we have on tap. One is just completed by Dr. Akiko Awasaki, and that study is actually looking at sex differences in the autoimmune system or the immune system as it relates to women and men. And that also has been a very successful study under her great guidance, where she has found that the response of the immune system is different in women and men. Now, we know that women and men have different responses in terms of their immune system. We know that women are more likely to have autoimmune disease, for example, where we know that there are real tangible differences. But the question on the table was, how is the immune system reacting to COVID-19, reacting to the virus that causes COVID-19? And what she found was that the inflammatory response of men could be hypertrophied, could be greater, could be elevated than it needed to be, perhaps, if you will, in response to the invasion of the virus. And when that happens, you can have too much inflammation, too much of your body reacting to the invading pathogen. And on the other hand, what we found with women was that, yes, they had an inflammatory response, which they should have, because that's the immune system saying, get going, get working. But they also had what's called an adaptive immunity response, in which T cells were then being elevated at appropriate levels. And so there was a greater balance of the innate immune systems and the adaptive immune systems. And we believe that as a consequence of her work, which now is affecting the way we think about various ways in which the virus acts, we now can think about designing interventions for women and men slightly differently as a consequence.
Dr. Smith, how do you share that kind of information to women in the community? Because that's very, very complex.
Mm-hmm.
Absolutely. I think it's a lot about how you frame it. And that's one thing that is, done very well in the work of women's health research at Yale, is taking that science and then framing it in a way that's digestible for a larger audience. And I think it really does link up with, community and policy context, in the sense that a lot of what we talk to women about that we work with in the community is how the inflammatory system Dr. Mazure is describing is impacted by the social context. So things like early adversity and stress interact with that inflammatory response and systems to really, impact people's health. So there are ways that we can talk about that and discuss findings with women in community settings that can actually lead to behavior change and impact, for example, enrollment and interventions. We don't typically talk about, even in my work with depression, we won't typically say depression, but we'll talk a lot about stress, because stress can be something that's universal, experienced by a lot of women, especially a lot of parents, especially in the time of COVID, for sure.
Are you seeing an impact in these interventions? Are they working?
So I'll give you an example of one of the key interventions that Elevate is working to replicate in our states across the country. And it was started here at Yale in 2011, called the Moms Partnership. And that's the mental health outreach for mothers partnership and interventions. That intervention particularly is focused on addressing depression in women who are pregnant and postpartum and who are parenting. And so what we do in that intervention is actually take an evidence-based intervention to treat depression, cognitive behavioral therapy, or CBT, and we deploy it and disseminate it in a way that becomes accessible by a large group of women that might not otherwise be able to access services. So we do two things. We deliver the intervention in a community setting. So an example is supermarkets. We've been working with Stop and Shop and Shaw's and embedding the mental health interventions in a supermarket setting. We found that this is actually acceptable. So women like to go to the supermarket and receive mental health care. It's feasible to deliver. So we do it in a private space with a group of women, about 8 to 10 women. And we've shown that it's effective. So we reduce depressive symptoms, we reduce stress, we reduce anxiety. And it's also a sustainable model that can be replicated in other supermarkets. I think one of the key features of delivering mental health care for women in community settings is it reduces stigma. You're going to the supermarket, you're not going to a mental health clinic or a hospital. And we know specific to women from others we've talked to, they're fearful often of seeking mental health care, fearful that children might be removed from their custody. So delivering in community settings and in partnership with community agencies and programs is really a way to overcome some of that stigma and reduce barriers. The second feature of the Moms Partnership is we're focused on using a position called a community mental health ambassador. And a community mental health ambassador is employing a mother from the community, often with lived experience. So a mother who's experienced stress. And the community mental health ambassador works alongside the clinician to really co-deliver the intervention. And so this is a model that we call task sharing that has actually been deployed in global settings, but never tested in the US. So it's been one that it's almost like we're hearing about now with contact tracers with COVID.
Yes.
The idea of really using community members to support screening and intervention and connection to services. So it's similar to that model. And we absolutely, have shown effectiveness of this, which is why we're replicating with large systems. So I think also what's really key to the mission of Elevate is we're showing not only improvements in health, but we're showing improvements in employment. So women are actually more likely to be employed after the intervention than when they started. So that's tremendously exciting, not only for the impact on women, but on women's children and families and communities.
Well, do you see that this community mental health ambassador is something that more people will adopt or more organizations will adopt?
We think so. So we're continuing to do a lot of research on the topic. We're looking into the cost effectiveness. We're looking into the training, looking into how well, something we call fidelity, how well the community mental health ambassador is delivering the intervention as compared to, a gold standard. It's similar to a community health worker model, again, that's being used and being reimbursed in some states, but that's where really the policy piece comes into play. But we also think as we're having a larger discussion in our country about equity and health equity and women's health equity, we also see this model as really being essential to culturally tailoring and adapting interventions. So I think that has a great opportunity as well.
I was also surprised, by the way, when you mentioned supermarkets. It's such a public place. I would think that would not be a good place to discuss something so serious.
We intentionally chose supermarkets. I mean, I've been convinced. We intentionally chose them because we actually asked women, when was the last time you did something for yourself? And so many women said, who were busy and had multiple caregiving responsibilities and demands, so, the supermarket, I went shopping. And so, we do have a private space in the supermarkets, usually upstairs, a group room. So it is, we are able to maintain confidentiality while delivering it in this manner. But it's certainly a model that we've had a lot of interest in and hope to replicate.
Dr. Mazure, is the partnership with Elevate really a way to underscore how health and socioeconomic status of women directly impacts the health of a community?
Yes, very much so, Jocelyn. I think that all along we've had a growing sense that there was a need to have really what we call a policy initiative within women's health research at Yale. And in many ways, this partnership with Elevate really fulfills our fifth initiative, the others being based on more biomedical research as well as communication and education. But this particular initiative really is so important to women's health research at Yale because I can tell you that over time, now having done this for a long time, I've been part of many committees nationally and even internationally, and reading guidelines for how you deal with the opioid epidemic or how you deal with Alzheimer's disease, given the growing number of individuals who are suffering from that disorder. And you'll read these reports and they'll go on and on about all different important things they could do, should do, we should all do as part of governmental policy. And the only time that you read about women within these reports is in terms of women as caregivers. They're never talked about as individuals who may suffer these disorders, who really have to be thought of in terms of helping them as well and lifting the health of women so that they too can live in a way that allows employment, allows a profitable life for them. And so this interaction that Megan and I have continually about how do you blend this research together so that it actually has a big practical impact is really our goal.
Now, key to all of this, Dr. Mazure, is science. Research which really leads to critical treatments and prevention strategies, which is a major initiative of women's health research.
That's right. In fact, all our scientists that we've been involved with over the 22 years we've been in existence know that every time we talk about science, we talk about what the practical benefit of the science will be. Initially, 23 years ago, our first grant was from the Donahue Foundation, to which we will forever be grateful for them starting us off. And one of the things I learned from the trustee at that time, Ray Andrews, was the importance of thinking about practical benefit. It's very much a part of their thinking. And I took that and made that a fundamental part of women's health research at Yale. And I think today it's even more evident that everybody's on board with that concept that you don't do science just for itself. Science can be very exciting. It can also be long and tiring and tedious, but it can be very exciting. And yet the goal is a program of research that reaches an end game where people benefit. And that really is our goal.
Absolutely. Dr. Smith, how does the science tie into community intervention and public health policies?
So, I mean, the science really undergirds all we do for community intervention and policy. And I think that's quite evident. And, when we're talking with a government leader, a government system, we know, the government dollars that we're working with in these systems really dwarf, philanthropic dollars and commercial dollars. And so these government systems want to see evidence. They want to see the science. They want to understand where the intervention came from, how it was developed. So it really has required interdisciplinary science and team science to develop this innovation. So it undergirds all of it. I also think that, there's new science that's coming out around, it's called implementation science. So actually studying how interventions are disseminated and delivered and how they're influenced by context, by communities and by environment, for example. So we're working on something at Elevate also called triple bottom line science, which is looking at how, the environment, the economic and the health context of women interact with one another. And then we're developing interventions to address those three things. So it becomes a partnership across multiple disciplines.
Can you share some preliminary findings?
It's early on, but I think the finding I shared about actually being able to show that an intervention to treat maternal depression can change employment. That has been really essential and critical, especially in the current context of COVID, where for low-income women, the additional stress of caregiving, and then for many women being disproportionately impacted by unemployment in the time of COVID, that finding has become really salient to many policymakers, that connection around mental health and employment.
One other thing, Jocelyn, I made about Megan's work is that when COVID hit, we all had to go, as we are right now, to remote communication. So here are these women who are used to coming together in the community. And Megan, maybe you want to say just a word about what you were able to do in terms of moving the intervention to a remote or virtual platform.
Thanks, Carolyn. I mean, it's a big thanks to our team where there's a pivot really in the span of 3 weeks to deliver all of the interventions in a virtual platform. And, all of us are familiar with how, you might do telehealth one-on-one with a provider. What was a difficult, complex problem was, how do you do a group intervention on a virtual platform? So we were able to develop that and pivot in a way that, when women are really longing for social connection, we were able to still be there and deliver those interventions that support that connectedness. So all of our sites have been able to pivot. And, even in sites like the correctional system, where we've been reading about, really impacted heavily by COVID and changed the dynamics and the demographics, but it's been very successful. So we're writing up those findings now. So to be continued.
All right, we'll be looking for those.
And one last,
go ahead.
just to expand on that, and I know you want to get to questions probably pretty soon, but just listening to the discussion and making it a conversation as you invited us to do, it occurs to me to say that both Megan and I share this interest in depression. My own area of work has been historically depression and stress. But in these conversations where we talk about the way in which you can make an impact, and listening to your question, Jocelyn, we've talked about the potential to take other kinds of treatments, other kinds of therapies, other kinds of interventions into the community. So whether it's a cancer-based information or information program that we're bringing to individuals, or actual treatments that we're bringing to individuals, that we reduce the cost of this effort. We can show empirically that they work, so that state governments, federal governments, insurance companies will willing to pay for them or share that load. And then as a consequence of that, individuals benefit and women benefit. And as women benefit, we also know from the data that families benefit. Mm-hmm. So I think it can be a win-win all the way around. And it's also a template for how to move other findings from science that we have available to us now empirically into the neighborhood.
Yes, we do have questions already, but before we get to them, I do want to get to the both of you. What major conclusions would you like our audience to draw from this conversation?
Carolyn, you want to start and I can add?
Well, I'll jump in and say that I think we need to continue research to unmask both biological and psychosocial variables or lived variables that affect health. And that really has to be supported. And there are two ways in which we have to approach that. We have to approach that in terms of very challenging avant-garde issues like COVID-19, like the opioid epidemic, like Alzheimer's disease, like depression. These are pressing concerns, while we're also continuing to learn more about cancers, cardiovascular disease, autoimmune disease, all these other conditions that women suffer. And then by studying sex and gender differences, really having the tide lift all boats where men and women benefit. And that really seems to be the number one objective for us as a takeaway for everybody to be thinking about.
And I would just add to that, I think, taking all of that and moving upstream and thinking upstream. So, we know that the circumstances that we live and learn and work in impact our health, and particularly for women. And so thinking not only about treatments, but, as Dr. Mazure described, thinking about upstream forces. And so thinking about the social and the political and the cultural context that we all live in and how that impacts our health is also really critically important. And finally, I would just say, what Dr. Mazure described, the different interventions and the diseases being researched at WHRY, Women's Health, is it's across the life course. So, the example of autism spectrum disorder, and then going to Alzheimer's, and how they're linked with certain processes and etiologies, and a better understanding of that really improves health across the lifespan.
And I would be remiss if I didn't add to that, and this is how our conversations go.
This is good.
I would be really remiss if I didn't add that we talk a lot about the intersection of race and gender. These are things that we really have to integrate into our work more fully. We already do work in those areas, but we have to do more of it. There are conditions like maternal mortality, for example, that our data are terrible in the United States. I mean, maternal mortality is rising while it's going down in all other developed economies. It's essentially comparable between the US and Iran. I mean, it's a disgrace what's happening, and it's hitting women of color, particularly Black women, much harder than it's even hitting white women. And so as a consequence, we have to look at all women, but we have to look at why is it different? And that's going to involve biology, but it's absolutely going to involve social values, social issues, healthcare access, all sorts of other issues that really need to be brought into the picture.
How can the audience learn more about what you're doing and to support your efforts, Dr. Mazure? I know that Women's Health Research at Yale is self-supporting, and that you raise money to fund the research and other educational and communication efforts, and to help with partnerships like the partnership we have with Elevate.
Mm-hmm. Right. Well, we're very interested in building further partnerships, national partnerships, and so on. One of the things that people can do is they can go to our website, they can sign up for our newsletter. We send it out in print or we send it out electronically. It goes out quarterly. It's more like a small magazine, and it tells you a lot about the kind of research we're doing, the kind of teaching we're doing, because we're mentioning the next generation. The next generation really has to be taught about what we know now and how to think more broadly about sex and gender and studying women. So we're very committed to these things. People can learn about them through the newsletter. They can get involved with us with social media, pass along our information, and really become part of our larger sphere of influence so that people are informed about this. It's so important to be an informed consumer with regard to your health care. Many people, for example, still think that breast cancer is the greatest killer of women in terms of cancer deaths, and it's really not. It's lung cancer. And the list goes on of things that we really should know about, should think about as we want to take good care of ourselves. And we're happy to provide that kind of information through our outreach, and we would love it if people got involved with us.
And we will share that website at the conclusion of this webinar, so look for that as well. So let's get to our questions. We have quite a number of them. So the first one I have here is that should men be concerned that we have not been studying sex differences?
Well, I'll jump in on that one, Megan, if you'd like.
Thanks, Karen.
I would say yes. I think the answer, though, is that men clearly have women in their lives that they love. They have mothers, they have daughters potentially, and others of wives, spouses, partners, others that they love and care about. And so they want to care about them, they want to care about their health. And so they should be concerned if we're not studying the health of women. But I think equally important is what we were saying about studying difference, or the influence of sex and gender on health. It's going to help everybody at this juncture. It's going to influence us in terms of like the COVID-19 example that we gave a few minutes ago. Men were dying, still are dying at slightly higher rates than women from that disorder. But we were interested in studying that because when you see difference, it gives you a wonderful opportunity to learn more about the disease. If you have two groups of individuals that one is doing better than another, you can look at how the bodies of these two individuals are basically handling the disease differently and learn more about how to intervene with the disease. So looking at sex differences helps everybody.
Dr. Smith, did you want to add to that?
I would just second what Dr. Mazure said. And I think, also, I think for everyone, I mean, men can ask their clinicians, is this, more common in men than women? And the clinician may say, I don't know, and that's raising awareness of the importance of studying this.
Very good. And another question we have, as I said, a number of them. In what other ways is community-based participatory research used by Women's Health Research at Yale and Elevate? Are there opportunities for community members to get involved?
Absolutely. There's a link to the Elevate website on the Women's Health Research website that we'll be sharing at the end of this webinar. We encourage you to get in touch with us and contact us. Many of our partnerships across the country have been because community members, community organizations have reached out to us and had a conversation about what they're seeing in their communities. So there's absolutely examples of that. A lot of the work now we're doing around the role of environmental justice in women's health and how those are intersecting. There's a lot of work going on with environmental partners. When Dr. Mazure was talking about maternal mortality, of course, all the research coming out now to show that climate change and what's happening, on a global level is impacting things like maternal mortality and also disproportionately impacting, minority communities. So we're very interested in partnering with new community organizations and partners, and please do get in touch with us.
Dr. Mazure?
I echo exactly what Megan said. I think it's very important for the community to be involved. Fortunately, from the initiation of women's health research at Yale 22 years ago, we were very interested in having a partnership with the community, and we've been very fortunate to have an absolutely fabulous advisory council, members of the community writ large, and also very good partnerships with the Community Foundation for Greater New Haven, who have supported us, and others. It's just essential that we all work together and pull on the rope in the same direction.
Our next question is, what has to happen next to ensure that the momentum of this work continues?
Well, I think one of the things that has to happen is there has to be continued support for biomedical research, and that as biomedical research is understood more broadly as interfacing with economic status, with all of these other important social variables, that it's all one. We are a complete organism, but we live within an environment, and you can't understand health until you understand the effects of both. And I think that's really the direction we're going. That's the direction we need to go. We need to have basic laboratory science, clinical science, and community-based science. We need to weave that together in an integration that works for everybody. It sounds like a big task. It is a big task, and we need people's help in getting that task done. But it is actually possible to do, in my view.
And from your perspective, Dr. Smith?
Sure, I was just going to add to that because I think it really speaks to a lot of the work that women's health research at Yale is doing in terms of embedding training on sex and gender differences into the curriculum of medical students, for example. I think, Dr. Mazure, maybe you want to talk a little bit more about that and those efforts, because I think that also needs to happen to move this forward.
Yeah.
Elaborate.
One of the things that I often talk with people about is when people say, well, gee, does my doctor know about this? I said, just like Megan was saying a few minutes ago, feel free to ask your clinician and involve him or her in a discussion of this. But in the meantime, it's our job to make sure that people coming up that ladder really are already informed. And if your physician or clinician or care provider doesn't know about this, it's simply because they were never taught this. And so now we need to teach people this. We need to teach people this at the undergraduate level, at the medical school level. And we're very excited about our relationships and partnerships within the Department of Education at Yale Medical School, where we are changing the curriculum to add in sex and gender difference, but not in a way that's an add-on, but really an integration into thinking about learning medicine, learning biology, and in that process, learning about sex and gender and the health of women. And that's true for the MD program, the MD PhD program. And we're very excited about those partnerships so that we can change the way in which people coming out of medical school or going into research as physician scientists, clinician scientists, really integrate this into their thinking so we don't have to repeat our history of not looking at these issues.
All right, this question is, I was shocked to learn that researchers do not always use male and female animal models for laboratory studies. Now, is that changing?
Finally, it wasn't until 2016, unfortunately. We've been working on that for a very long time. And I have to give a lot of credit to the Office for Research in Women's Health at the National Institutes of Health. And that office, I sat on their advisory committee for many years, and still consult with them, and they have been responsible for changing the paradigm at the NIH in certain ways to accept this as part of what needs to happen. And the reason it's so important is because that kind of basic science on cells and tissues and animals really sets the stage for what will come later in terms of human research. And if you're getting all your data, again, from male cells and tissues and animals, it doesn't necessarily apply to models for humans who are women. So it's really important to do that work on female and male animals and cells and tissues as well.
All right, to both of you, can you speak to any new research on sex and gender differences in cardiovascular health?
Well, there's an area that historically, when you think back, had really been very slow to adopt any kind of view toward looking at sex differences. One of the first studies ever looking at the effect of estrogen to reduce the potential for a second heart attack was done in 8,000 individuals, all men. So all men were given estrogen rather than even give estrogen to women. Now, estrogen is a lipid-lowering drug, so you might think, well, that's valuable and worth doing, but why wouldn't you do it with women who already are individuals, like postmenopausal women who already are individuals who might be taking estrogen, who need to take estrogen? So the paradigm was so locked into the exclusion of women that cardiology was an area that was way behind. They are no longer way behind. They have done an amazing job of really trying to catch up and go beyond catch up to really have very avant-garde views of the fact that, as I was mentioning earlier, for example, younger women who have heart attack may have microvascular disease. It presents in a very different way from plaque or other kinds of conditions, and so has different symptoms and has different treatments. So I think that cardiovascular areas of referable to heart attack, referable to stroke are advancing. We have one study ongoing now in cerebral hemorrhage looking at differences in females and males where there appear to be significant cellular differences, and we're trying to understand how those relate to a larger perspective on interventions.
Okay, I just got to say, that's shocking to hear that they were studying men, estrogen in men, and excluding women. That just doesn't make any sense to me.
Right.
Gosh. Okay, Dr. Smith, did you want to say something?
I was just going to add to that from the social and community perspective as well. I think, an area where the cardiovascular researchers have also been intersecting with social factors in health has been around racism and discrimination, and studying those effects for, in particular, looking at Black women and how discrimination experienced over the life course and adversity that results from that discrimination impacts inflammation that's related to cardiovascular disease. And then also, Jocelyn, you were asking me before about community health workers. And this is an area as well in cardiovascular research where community health workers are being used to conduct community outreach and interventions around warning signs for heart attack with women, for example, and do a lot of educational interventions that are very effective. So I think there's a lot of opportunity there.
Dr. Smith, someone wants to know, can you repeat the 3 things your team is working on for triple bottom line, and why these 3 things specifically?
Sure. So the triple bottom line is thinking about health, thinking about the environment, so things like environmental justice, and then thinking about economic mobility. And so what we're basically positing is that we can design interventions and policies that can achieve all 3 of those, can really achieve improvements and optimal well-being across all 3 domains. And specifically, we're choosing those because those are really encompassing something, we call the social determinants of health. So thinking about environment, thinking about economic situation and circumstances, and then how those impact our health.
Another example of that that's really, I think, a good example is in depression, because the rates of depression in boys and girls are about the same, but around puberty, those rates start to diverge. and the rates become much higher in young women than in young men. And that stays elevated throughout life. Now, across epochs, the absolute amounts may vary, and across cultures and countries that may vary, but that's found worldwide, that women have more depression than men. And in the United States, it's about twice as much. So again, absolute numbers may vary by country or culture, but there's always that divide. So the question becomes, how much of that is biologic and how much of that is social? And we are certainly convinced it's both, that there's interplay of these things. There's no more kind of mind-body difference. It's all the same. It's one organism living in an environment. And so it's all interactive. And our job is to figure out the nature of those interactions.
All right, we only have 5 minutes left for our questions, so we have some more here. So let's get to a couple more. Can you talk about sex and gender differences in addiction? We all know that's a major issue right now in our country.
It's a very big issue. I just finished writing an invited paper on that to talk about sex and gender differences. So we really can say very clearly now that we know there are very significant and important differences in brain in terms of when you take an addictive drug. And we can also say that there are all sorts of different social experiences referable to taking drugs. And I'll give you just one example of all of this, and that is with regard to opioid addiction. Opioids really began to proliferate through prescriptions in the 1990s. It was fueled by misinformation from certain pharmaceutical companies indicating that they didn't have addictive properties, which is absolutely false. And when you look at who got most of those prescriptions, the answer is women. Women suffer more chronic pain, they go to the physicians for treatment more frequently, and they get more prescriptions for opioids. However, national studies also showed that if you look at men and women with chronic pain going in and reporting a chronic pain and trying to get help, women still get elevated rates of opioid prescriptions. When people finally caught on to the fact this was addicting women and that the major route to addiction for women for opioids was prescriptions, people started, of course, pulling back on that, and the medical community started to reduce that. But the problem is that women, when they're addicted to various substances, have a harder time quitting. That first of all, they get addicted faster and they have a harder time quitting. We found that in smoking, we found that in cocaine, we found that in alcohol. And I think it's really important to think about those differences, to understand them, and then to find different ways in which you design your treatments based on those differences.
Dr. Smith, are you seeing that at the community level?
We are absolutely seeing that, particularly around smoking. And we see working, with Asian American communities, for example, that's one of the factors that's comorbid with depression and also trauma. We're seeing actually that relationship between trauma and substance use disorders in a lot of the work we do. And so it's one thing that we're thinking about intentionally as we design interventions, that link between trauma and substance use, particularly for women.
I just want to get in one more question, and if we can just wrap it up fairly quickly. Have there been studies on how social media affects depression and suicide?
So I can start on that, and absolutely. There have been a number of ones. I think the question becomes the rigor and the methods used in the study, and how, that's a complex question and how we evaluate it. But absolutely a relationship between certain types of media and suicide. The difficulty is teasing out the causality. Mm-hmm. And, we would need to look over time with a lot of different measurements to really understand that it was causal.
So we are seeing an effect of social media on girls.
Yes, adolescent girls for sure.
Mm-hmm.
Dr. Mazure?
I think the only thing I would add to that is the importance of being very thoughtful and careful about where you obtain your information. And that goes for all health information as well. And I would say to people who always ask me, well, where do I go if I want to read more about particular kinds of conditions, disorders, or I want to read about health? One of the places I always advise people that they can go is to within the institutes of the National Institutes of Health. There you can be sure you're getting real information. And some of those websites are really quite good and tell you a lot. And there is a website for the Office for Research for Women's Health.
Well, I want to thank you both, Dr. Smith, Dr. Mazure, for this enlightening conversation, and to Dean Brown and the Yale Alumni Health Network for their support. And thanks to all of you for watching. For more information on women's health research at Yale and Elevate and how you can support their mission, go to medicine.yale.edu/WHR. The website will be on your screen momentarily, and enjoy your evening.